So now we will talk about cervical cancer. Epidemiology. So in the United States in 2007 we had 11,150 new cases with a death rate of 3,670 patients, which justifies all the efforts we make to improve screening, early detection, and knowledge about the nature and biology of this disease. Lifetime risk of a healthy woman not exposed to particularly high risk factors is of 1 over 168. Less than 2% of cancer deaths in women is attributable to cervical cancer. Overall survival is quite good and depends on early diagnosis. If you consider overall survival for all stages of the disease from stage 1 to stage 4, we have more than 70% 5-year survival. If we subdivide the 5-year survival according to stages, we can see that very significant differences are reported from early stages to late stages. So in the first stages we will have a high survival, in the last stages low survival. Cervical cancer is still the #1 cancer killer worldwide among women, and you have to attribute this data mainly to low resources settings like Central America, Southern America, Far East Asia, and mainly the African continent, with a lot of deaths, which justify all the efforts we spoke about yesterday. Pap smear. You have to remember that pap smear decreased very dramatically the incidence of the invasive disease, with all the exceptions that we know about the biology of the disease itself. Etiology: cervical cancer is actually considered a sexually transmitted disease on the basis of the HPV infection and its effects upon the cervical epithelium. HPV DNA is present in almost all of cases, both invasive and preneoplastic, so it's the real cause of the disease itself. Some strains have a predilection for the genital tract, and these are serotypes 16, 18, 31, 33, and 35. There is a little understanding on why small subsets of women affected by HPV have different behaviors compared to the natural history of the 16 and 18 related pre-invasive and invasive cancers. So we can observe small subsets of patients 16 or 18 positive with different natural history of the disease, with more frequent spontaneous clearance of the disease, and on the other hand with very aggressive course of the disease without the steps of scene 1, scene 2, and scene 3 preneoplastic disease. So some cases have a very quick progression to cervical cancer without the intermediate steps of the preneoplastic disease. So some are very quick. HPV infection can be latent for many years before inducing the biological transformation of the cervical cells, so there can be a latency which prolongs the natural history of the disease, and in this case the opportunity to interfere with the natural history of the disease itself with adequate diagnostic intervention is more easily obtained. Risk factors. Risk factors are: being a sexually transmitted disease, sexual habits are quite important to be analyzed. Early stage of first intercourse is clearly demonstrated to be a high risk factor. Number of sexual partners is a relevant factor as well. Cigarette smoking is proven to reduce cell-mediated immunity at the level of the squamous-columnar junction. Mainly dendritic cells and Langerhans cells are significantly reduced in the cervix of smokers, and this is very clearly associated with a quick progression and a more frequent persistence of the disease and an earlier onset of the disease compared to non-smokers. Lower socioeconomic status increases the risk of cervical cancer. High-risk partners strictly correlated with the disease. Other sexually transmitted disease, mainly chlamydia and herpes, are risk factors for cervical cancer. Up to 70% of US population is infected by HPV and thus exposed to the risk of disease development and progression. So as said, the risk factors are sexual habits, early age of first intercourse, number of sexual partners, cigarette smoking, lower socioeconomical status, high-risk partners, and other sexually transmitted diseases. Prevention is done with education of both providers and patients as far as it concerns HPV and the correlated risks to the development of cervical cancer. Adequate education to young subjects about sexual behavior and protection and about the biology of the virus. Education about the risk of an early onset of sexual activity, mainly if not protected, and sexual protection. These are the guidelines which preceded what we analyzed yesterday. Screening should begin approximately 3 years after a woman begins having vaginal intercourse, but no later than 21 years of age. Screening should be done every year with regular pap tests or every 2 years having liquid-based cytology tests. At or after age 30, women who have had 3 normal test results in a row may get screened every 2-3 years. However, doctors may suggest a woman get screened more if she has certain risk factors, such as HIV infection or a weakened immune system. Women 70 and older who have had 3 or more consecutive pap tests in the last 10 years may choose to stop cervical cancer screening. Screening after a total hysterectomy with removal of the cervix is not necessary unless the surgery was done as a treatment for cervical cancer. Nowadays, guidelines state that the beginning of the screening program is scheduled at the age of 25, and this is the main difference because the age of 25 with the biology of the HPV DNA test we can detect too many regressive infections not correlated with neoplastic disease. So nowadays we delay slightly the beginning of screening with no relation at all with the age of the first intercourse. So there is no difference between conventional cytology and liquid-based cytology. Nowadays, women should never quit the screening program, not even at more than 70 years. After a total hysterectomy for benign conditions, a patient can stop the cervical cancer screening. The rate of false negative pap smear results is quite high, that is more than 30%. The latency period from dysplasia to cervical cancer is very variable according to the patient immunological status, but no less than 15 years are needed for the evolution of the disease. 50% of patients who developed cervical cancer did not have a pap smear in the previous 5-7 years. The late stages of the disease, with 41% of deaths for cervical cancer, occur in patients more or equal 75-year-old. Symptoms. What happens in situations of invasive disease, not pre-invasive, not preneoplastic, and not intraepithelial, CN1, CN2, or CN3. The disease may still be silent, symptomatic, or it can occur with very specific symptoms, not particularly related to the presence of a malignancy. You can have also postcoital bleeding. Almost 85% of patients report small amounts of bleeding after sexual intercourses. Full vaginal discharge is very frequently confused with septic infection, with bacteria or is contamination of the lower urogenital tract. Abnormal menstrual bleeding, which can be very confusing according to the menstrual story and habits of the patient. Pelvic pain. Unilateral leg swelling and pain, which is very frequently correlated with pelvic and obturator lymph nodes involvement. Generally, the pain is on the inner side of the upper leg, usually unilateral. Pelvic mass detected occasionally during a gynecological consultation for other reasons. Macroscopic gross lesions at visual inspection. Okay. History. The majority of cervical cancer are squamous cell carcinomas in 80% of cases. 50% are glandular adenocarcinomas, starting from the inside of the cervical canal, from the inner portion of the squamocolumnar junction, or from the columnar part of the epithelial surface. An even smaller amount is of adenosquamous type. A few others are present as well. When we talk of invasive cancer, cervical cancer, in general we talk of squamous cervical cancer adenocarcinoma as a quite different biological natural history. It has a different prognosis and evolution. It has a quick array of diffusion to lymph nodes compared to squamous type, and in general it has a different response to both surgery and adjuvant therapy. Staging. In the recent past, cervical cancer was a clinically staged disease based on the TNM stage system. Relied on physical examination, biochemistry, and imaging. The moment a surgical staging system is preferable because of the obtaining of much more reliable prognostic factors. The surgical specimens are one of the most reliable predicting factors of recurrence of the disease and the spreading of the disease to lymph node stations. Another reason why clinical staging systems have been largely used for a long time in clinical practice is that one of the main points of reliable treatment for cervical cancer has been radiotherapy. Radiotherapy is being used in less cases as first-line therapy, but more as adjuvant therapy after surgery. Many centers in Northern Europe still perform radiotherapy as first-line treatment, with brilliant results. The reason why radiotherapy has passed on the background as therapeutic option is that it is correlated with complications, especially in young patients, in the bowels, in the rectum, in the bladder, in the ureters, mainly chronic enterogenital fistulas, which are quite difficult to be managed by surgical or medical treatment. We have stage 1, that is an invasive cancer limited to the cervix. These are cancers at the early stage of the disease and can be well controlled with conservative treatment. We have stage 1A1, stage 1A1, that is less than 3 mm deep invasion and less than 7 mm in linear extension of the disease. Stage 1A2 is invasion depth of 3-5 mm. Stage 1B1 is invasion depth more than 5 mm and linear extension less than 4 cm. Stage 1B2 is invasion depth more than 5 mm and linear extension more than 4 cm. Stage 1B, 1 and 2 are clinically detectable disease. When the gross appearance of a stage 1B is more than 5 cm in linear extension, surgery is not the same curative performance as in a 1B1 stage, and neoadjuvant chemotherapy is indicated. So, neoadjuvant chemotherapy is indicated in stage 1B2. Microinvasive stage 1A disease diagnosis must be based on a conization technique, not a simple single biopsy, because you might miss the point of invasion and you can't have a correct measurement of the linear extension. You must have both parameters, linear extension and depth of invasion, and this is impossible to attain on a simple single biopsy. You have to provide a conization specimen to the pathology to allow the diagnosis of a microinvasive disease. If a suspicion of microinvasive disease is reported by the pathologist on the bioptical specimen, a conization must be performed to exclude or confirm the hypothesis. The other option, obviously, is the diagnosis on a hysterectomy specimen. Usually the diagnosis of a stage 1A or 2 or 1A2, 1A1 or 1A2 is invasive disease on a hysterectomy operative specimen is an incidental diagnosis. In general, the hysterectomy has another indication, and the pathological report tells us that a stage 1A disease is present, no lymphatic or vascular invasion. So an important point is that the pathology must exclude any invasion of the lymphatic or vascular spaces in the conization specimen. They can be successfully treated with fertility-sparing techniques, with conservative treatments. In general, a conization with free surgical margins, the other prognostic factor determining the radicality of the cone, can be curative, with 100% success rate and no recurrence of the disease. In general, a conization with free surgical margins can be curative, with 100% success rate and no recurrence of the disease. These patients should be referred to consultation to a second-level referral center, mainly because of the pathological expertise needed. Very few general pathologists are so familiar with microinvasive disease that they can detect with particular attention the depth and the linear extension of the disease. Misdiagnosing 1 millimeter of invasion can really change the prognosis of the patient and can really change the recurrence rate in selected cases, the under-treatment of a 1B case that has been wrongly been identified 1A2. Remember that cutoff of 5 mm distinguishes the two stages. These patients are very young women, frequently women with fertility desire, and thus the problem must be discussed in detail by expert staff of gynecological oncologists. Stage 2. The upper vagina is involved by the tumor extension. Stage 2A. Involvement of the upper two-thirds of the vagina without parametria involvement. Parametria are represented by the broad ligaments, the cardinal ligaments, which is Mack and Rhodes ligaments. The parametria are the first direction of extrauterine progression of the disease. Through the parametria, the disease extends towards the lateral pelvis, towards the first lymph nodal stations. Stage 2B, when the vagina is involved together with a parametrium. Parametria involvement is detected by the inspection, by manual inspection, rectovaginal inspection, or by imaging. Mainstay of imaging in this case is MRI. In stage 3, the tumor involves the lower vagina and it reaches the side wall of the pelvis, so the entire length of the parameter is involved, and the malignancy reaches the bony pelvis or the tumor involves the ureters. Stage 3 is typically identified as urogynecological cancer, cervical cancer, because ureter involvement is present, because hydronephrosis is present, because frequently patients in the progression of the disease develop kidney failure. Stage 3A, we have a vagina only. Stage 3B, side wall of the pelvis or urogynecological involvement. Stage 4, we have bladder, rectum, or distant metastasis. In stage 4A, we have pelvic involvement. In stage 4B, we have extrapelvic involvement. Treatment. Treatment of early stages is conization or simple hysterectomy. In advanced age groups, in case of no fertility desire. From stage 1B onwards, radical hysterectomy, which is the removal en bloc, single specimen, with or without the ovaries according to the patient's age, and the periuterine tissue. That is why it's called radical and not simple hysterectomy. Then the lateral, anterior, and posterior parametria are removed. Ovarian preservation is possible according to the age of the patient, just to avoid surgical menopause. Chemoradiation therapy can be associated or not, according to prognostic factors related to the surgical specimen. In case of advanced disease, so from stage 1B, 1B2 onwards, a multi-step protocol of therapy is needed, in general for 5 weeks of chemoradiation, with the option of 2 or more implants of brachytherapy depending on the depth of the tumor invasion, with simultaneous cisplatin-based chemotherapy used as radiation sensitizer. Platinum-based chemotherapy is not applied as directly reducing the tumor size or growth, but is used to improve the radiation effects. So, just to repeat, we have stage 1 is invasive cancer limited to the cervix. They can be well controlled but with conservative treatment. Stage 2, the upper vagina is involved. Stage 2A, involvement of the upper 2/3 of the vagina without parametria involvement. Stage 2B, upper 2/3 of the vagina together with a parametrium. Stage 3, you have also involvement of the lower vagina and the parametria. Stage 4, bladder, rectum, or distant metastasis. Treatment can be in early stages, conization or simple hysterectomy. In advanced age groups, in case of no fertility desire. From stage 1B onwards, radical hysterectomy. Okay. In case of advanced disease, so from stage 1B2 onwards, a multi-step protocol with chemoradiation, generally for 5 weeks, can be is needed together with brachytherapy if needed, and simultaneous cisplatin-based chemotherapy used as radiation sensitizer. Recurrence. In case of recurrence, we have the same clinical aspects as the primary disease, together with systemic elements, such as weight loss, infertility, and loss of appetite. We can find abnormal vaginal bleeding and pelvic pain, pain and swelling of the legs, full discharge, and different signs of distant metastasis according to the site. At the clinical inspection of a previously irradiated pelvis, it's difficult to distinguish between radiation effects and the presence of a recurrence. Recurrences are still managed with chemoradiation, both in a curative and palliative fashion, especially in women who have not received a prior radiation therapy but only underwent surgery, or they are managed with second surgery, mainly in case of isolated recurrence site, with a single well-identifiable disease involving no more than one organ. Second surgery must be considered as a therapy option for recurrences only after a systemic study of the patient. There are 2 groups of patients when treated. Okay. Topotecan is another drug quite often used in recurrences and in third-line therapy of recurrent cervical cancer. The response rates are mainly influenced by a previous similar treatment. Okay. Using a multi-drug scheme in recurrent cervical cancer does not reduce quality of life of the patient. Response rate with cisplatin alone is lower. Survival with single-agent chemotherapy is lower. And the advantage of adding topotecan is quite clear. This is the reason why in many oncological centers radiation therapy is still the mainstay of treatment, since the results for stages were expected survivals where expected survival rates are good are comparable to radical hysterectomy and other non-surgical protocols.